Welcome, everybody, to Chaps Many Cultures, episode 163. Today, we're going to pick up on a topic we talked about before, how culture and health care and health prevention and health maintenance go together. We're not going to hear from a medical professional. We're going to hear from somebody who is in corporate health and has a very unique perspective on that topic. Stay tuned.
Healthy.
I'm healthy. No. Thank goodness I'm healthy. Absolutely. So we talked about this before. By the way, this is Two Chaps Many Cultures, the show about the business of culture and the
culture of business.
There we go. And we had this topic before. We talked with Dr. Stacy Walton, who shed light on cultural differences and even inequalities in the healthcare field as it pertains to ethnicities and socioeconomics and all sorts of other cultural factors. Today, we're going to shine some light on that very topic again from a different angle, though. Wouldn't that be nice, Brett?
I think many angles. Of course, we need many angles and smarter people than us.
Well, we have somebody who can shine some light on the angle. My dear friend, Aaron Webb is here with us today. Thank you, Aaron. Thanks for joining us this morning.
Absolutely. I'm glad to be here. Thank you, Brett and Christian, for allowing me to be here.
Where are you joining us from this morning?
I'm from my southeastern Tennessee office, which is in Chattanooga, and a beautiful downtown area, and happy to be here with you too.
So tell our audience what and it says in your name here, it says Esquire, so that would lead me to suspect you have some legal educational background. What brings a lawyer into the healthcare field?
Well, I appreciate that question. And I am what I like to call a recovering lawyer, in that I do have a law degree. I'm trained in business law, and specifically trained in business with a healthcare focus. So when I was in law school, you have an opportunity to specialize either in advocacy, which is helping people in a courtroom, or business. I specialized in business and with a healthcare focus. And so it provides me lots of background and structural analysis framework to think about the work that I do every day.
So what do you do now? Who do you work for, and how do you bring your expertise to serve people?
Absolutely. Well, thank you for that. I work for a company called Common Spirit. We're the largest not-for-profit hospital system in the United States, with 150 hospitals, 150,000 employees. We have over 1,000 care sites, 25,000 owned physicians, I should say. And we have several business lines, of which I am over our senior living business line, and I'm the president and CEO. And we're a nationwide organization, both with Common Spirit and the group that I am over, which is called CI Living Communities. Right. And so I enjoy every minute of it.
So full disclosure, people, as you're watching this, Aaron and I, we go back a few years. So we've known each other a little bit. And I think I have a hunch what part of your personal story brought you into that specific field that you're in. You're one of how many siblings? 5 or 6? How many of you are there?
Youngest of 6, 3 girls first, and then 3 boys, and I'm the youngest.
And you were always the caretaker in your family, weren't you?
Always the caretaker, and just naturally, I was that one who wasn't intended to be born, as my parents would tell me all the time. But I was very close with my parents and my grandparents, and I'm certain that has a lot to do with how I ended up in the senior living arena, is from caring and listening to their stories. And then there's a cultural piece too, Christian, and that is often in the African American community, we don't like to send our family members to senior living for a number of reasons. And So I was brought up with the value of what good care looks like. And so I try to take those cultural values that I learned as a child and as a teenager and as a young adult into now a more business framework.
So
that's fascinating. No, I just wanted to pick up on that question because I think that I wasn't aware of that. So is it a reticency of trust of the healthcare system? I mean, and I'm just referring back to what Christian said in our conversation with Dr. Walton in terms of that initial trust of a framework that is of care. Yeah.
So it's two things, Brett. I would say, first of all, there is that trust factor, and it even plagues us with COVID, the African-American community with COVID right now. There's just a distrust of the medical system based on a good reason. In addition to that, though, in senior living, I'll use my father as an example. He was in his 80s when he passed away, and he would have been a perfect candidate for assisted living. And he was born in the 1930s, and he had to remind me, he said, listen, I was born in the 30s. He said, the people who are my age, they were not nice people to me when I was in my 20s, 30s, 40s, and 50s. He said, so I really don't want to be in a space where I could be sitting next to some guy who has a flashback to 1945 or 1950 and treat me that way, because
right.
Very few African Americans in senior living as residents. We call them residents versus patients, again, for a lot of historic reasons. So he didn't want to be that one. So I would say the medical basis of trust and also comfort.
Yeah.
Well, there are multiple stories or multiple narratives that would lead us to understand why the African American or large parts of the African American community are reticent or skeptical of the medical field. Stuff comes to mind like the sterilization experiments that were done in North Carolina and all sorts of cruelties in the name of science, right? How does an African-American professional in a leadership role today in 2021,
right?
How do you counter that? How can you re-educate your residents, your patients, your market? Or how do you change some of those systemic inequalities in corporate health?
Well, that's a great question. It's difficult to do, but I like to think even things like this conversation we're having today will reach audiences and will reach people who it'll just make them consider some of those inequalities and disparities that occur. But primarily, one of the first things I did when I became president and CEO of the current organization is I wanted a listing of how many non-white residents did we have, and we have thousands of residents, and how many non-white employees do we have at the caregiving level? Because remember, in my organization, it is the CNAs and the licensed practical nurses and RNs who have the most physical interaction with our residents. I wanted to see just what were the numbers, and as you can imagine, or may not be able to imagine, but hopefully your audience will have an appreciation for this. The numbers are in the tens of percent. In terms of both resident as well as employees who enter this field. And again, there's historic reasons and some other reasons for that. But one of the things you have to do is just simply be intentional. There's an article I was interviewed with a group called Senior Housing News, which is our Wall Street Journal of in our world, and so they that question. So you have to be intentional about where you recruit for residents and where you recruit for employees. And it's not about quotas or affirmative action or anything like that. It is simply about seeking out people who may not know what senior living is. And then we have to break up stereotypes and myths about what it's like to live in senior housing and also to work in senior housing. So it's a daily grind.
Is there also a limitation of access in terms of finances, that there's a certain money threshold that you need to cross in order to be able to afford senior living with an organization like yours?
So that's one of the biggest thought processes that comes up sometimes about this area. I should have mentioned that we have 4 business lines within what we call our ministry, because we are a not-for-profit and we are part of the Catholic faith. We're faith-based organizations. CHI Living Communities would be. We have independent living, which is just basically rich older people who don't, and I say rich, well-to-do older people who don't want to take care of a home. They're completely independent. They drive. We have places they have garages, kitchens. They're completely independent, but they have the option of having us help them if they like. Those are the most expensive places to live. Second is assisted living. That's where you're not necessarily rich, but you have excess money, or your family's pooled money together to care for you because you're starting to have trouble with showering and washing clothes and cooking and things like that.
Mhm.
Third would be our memory care, dementia based. And then fourth is what you think of as a nursing home. Okay, so all of the first three that I mentioned are private pay. That's where families do have to pay. That last one is paid by Medicare, or in some cases Medicaid. So there's not a financial barrier, at least one of our four lines of care. The other three, whether you're black, white, no matter what your race is, most families band together with brothers and sisters, helping mom or dad afford our living. So affordability is not the key for diversity in what we do. It's that trust and that comfort is every time rises to the top.
So I know we talked about this over dinner the other day. There's a number of strategic or intentional activities that your industry, or in this case, your organization in particular, are undertaking. You mentioned to me the other day that your organization has partnered with a historically black university here in Atlanta to do exactly what? Can you describe how that is going to break down those racial or inequality barriers?
Absolutely. So I'll cover that on two fronts. One is the senior living front. The other is just regular health care. We call it acute care. You have something happen, you go to an acute space like in a hospital. So has a 10-year, $100 million partnership we formed with the Morehouse School of Medicine. Again, think about years, $100 million of partnership. We're going to, and the reason we chose, I should say, Morehouse, and Morehouse selected us, is first, our CEOs of our entire organizations are really good friends, but Morehouse is a trusted name in the African-American community. It's, again, the Harvard of the Black community, so to speak. So they have a lot of trust. And Morehouse School of Medicine is a medical school that is affiliated with Morehouse College there. And so we wanted to partner with a university, or in this case, the Morehouse College of Medicine, so that we could have an immediate credibility with African Americans in terms of that should immediately remove the trust issue. Doctors and nurses who are black or not necessarily black. There are several white doctors at Morehouse School of Medicine who teach and who are students there and soon to be doctors. But there's a trust inherent built in. And so what we're looking to do, to answer your question at its base, what we're looking to do is to break down those barriers to access. For example, many African Americans don't want to go to a physician unless they go to another African American physician, right? And so by partnering with the Morehouse School of Medicine, there's going to be a ready pool of physicians that will be, coming out of that college. And if we can get them paired up in the community right now, doing community service in certain ways, or helping give COVID vaccinations, for example, or doing all sorts of other community-based activities, that's going to, by nature, give both the Morehouse School of Medicine students access to practice. And it's also going to give people in the local communities, the African-American communities, access to the medical field. And so from that very basic connection, we hope to increase the number of Black physicians and nurses, I should say, as well, create access channels, and create future partnerships that benefit not just the Atlanta region, but the entire country. Because again, by partnering with us, we are a national company. We're in 21 states. And so we plan to duplicate what we're going to do in Atlanta across the footprint, such that one day, as residents graduate from the Morehouse School of Medicine and they're ready for their residencies, we can hopefully get them all over the country. So we're going to help create curriculums that are culturally based, culturally correct curriculum to teach them how to care for African Americans and to create trust with African Americans with the medical field.
Nice.
The there are specific, and we talked about this with Dr. Stacey Walton and a few other guests and I've had experience. I learned this working with the National Kidney Foundation here in Chicago, where there was this kind of specific maladies or predeterminations of conditions that at the African American community where it showed up more often.
Yes.
And so can you speak a little bit more and expand on that from a how as a corporate approach in terms of drawing on that? Yeah.
Absolutely. Brett, I really appreciate that question because, the civil rights movement had at its bedrock that there's no difference between, the races. Everybody bleeds red. And it was a cornerstone of the civil rights movement to say that. And while that's true in many cultural aspects, science is now showing that there are some differences in how different modalities should be implemented within certain racial groups. And to answer your question specifically, right now we are investigating and about to launch and a study. Well, we're going to launch a new way of treating hypertension, high blood pressure in the African American community based on research. And that research is, African Americans suffer from hypertension at a higher rate than the general population in the US. And so you could say, well, that's all diet and exercise. Black people like to eat stuff high in salt, and they don't exercise. Well, the dietary component of that has some validity to it. And that's based out of often what is considered the slave diet. So salt was cheap back in the day during slavery. It was a way to cure food and make it last longer without refrigeration. And so blacks did eat salt. And so some of those recipes still exist to this day, right? Christian and his wife Brigida came to a family gathering of mine for Thanksgiving one year. And we had all sorts of unique foods that were there. And it was a real cultural experience for all of us. But the science says there is this theory that has been proven, actually, that African Americans who descend from slavery, African American bodies hold on to salt differently than other bodies. And it has to do with the transatlantic slave trade. So for those who might not know what that was, there was a process of transporting slaves from Africa to the U.S. for slavery. It took months to happen. And if you've not seen the picture, slaves were packed like sardines. I shouldn't say they were slaves. They were Africans who were packed sardines on a boat, getting very little water, very little food, and many died on the way. Well, one of the things that was studied by Johns Hopkins and Harvard and other medical research institutions was that what made some slaves live, what allowed some Africans to live and some who died. And so the theory is, it has been proven that Africans who were transported from Africa to the U.S., their bodies had a different relationship with salt. So when your body holds on to salt, your electrolyte balance is different. And so when you drink Gatorade when you're sick, for example, grandma always tell you drink Gatorade when you're sick. Gatorade is high in salt, high in sodium. That sodium is needed for electrolyte balance, which can leave your heart rhythm in the right rhythm and you live. So what happened is on the transatlantic slave trade process, African Americans who survived, bodies adapted to either were naturally inclined to or adapted to hold on to salt a different way. And we and the African Americans who are in the country today descended from slaves, they share those genetic markers, because if you look at Africans who come to the U.S. who were not part of the slave trade, meaning they voluntarily came here, there's a different relationship with their bodies, with how their bodies hold on to salt than the ones who died off or survived the slave trade to make it here.
So 400 years of slave diaspora causes a different physiological response to our environment, and therefore leads to different health risks for the Black population in the U.S. that is descendant of slaves.
Absolutely. You said quite nicely. And then you combine that with historic dietary patterns, again, high in salt dietary patterns with a natural inclination of the body to hold on to salt, and you have an increased risk for hypertension. The other thing on the treatment side of that, the standard treatment for hypertension in the U.S. for the average body, I'll call it the average white body, would be something called an ACE inhibitor, whereas proven that African Americans should be treated, the first line of defense should be something called a calcium channel blocker. So they both are first lines of defense against how to treat hypertension, but doctors, but they're different because the calcium channel blocker is better for African Americans.
So the assumption that, well, we all bleed red, right, and physiologically and genetically we're 99.9% equal. So what works to cure one body should work to cure others as well, and that's a fallacy. Then, if I hear you right.
That's correct. I would change one thing you said in terms of equal. I would say that the same. So just a slight, should the equal word separate but equal, a whole different legal analysis. But yeah, but are different. Our bodies respond.
The lawyer. Here it is again. The lawyer.
Hey, got to lawyer us up, right?
Right. Whole different
yeah.
But that's, and there are others. High blood pressure is one, but diabetes is another. The way you treat dermatological issues, they show up differently in African Americans, and often internal maladies can, manifest themselves through skin. And all of the studies that were done, all of the protocols, they weren't made for Black people weren't part of the research studies that led to treatment. And so there's all sorts. I'll give you just one last one that we deal with. And this is where I really became interested. When my wife and I began having children, the height weight charts always show that our children were in the 95th percentile in height, but 5th percentile in weight. They were tall and skinny, like we both were, I should say, at one point in our lives. And so what happened, our doctor back in years ago told us, he said, listen, don't pay attention to those charts. Those charts were based on white babies. Black babies were considered part of the growth, the height weight charts that were there, and your bodies are different. And if you compare to other African American babies, your babies are just, they're not underweight. And that was years ago. And so there are other things like that in medicine that doctors have adapted. We're going to teach, with this partnership, we're going to teach students those differences so that they can render culturally appropriate, culturally competent care.
So that would assume, though, and I'm only making this up because I'm white and I don't know this stuff, but if there's probably an underlying fear of Black parents, is my child is it a male fed, or is my child not getting enough nutrients? Am I at a disadvantage, or is my kid at a disadvantage from baby age on? What am I doing wrong, right? If I'm measured against the wrong comparison chart, right?
Absolutely. And I do want to say with there are lots of people who may be listening to this or watching this who say, well, wait a minute, I don't follow that. I'm mixed. I have one Black parent, one white parent. How does that work? And so the things about, they're not black and white. They're strong enough. They're significant enough to show up in medical differences that they need to be addressed. But please don't take anything that I'm saying as if you're Black, this is the case for you 100% of the time. If you're white, this is the case. According to my 23andMe results, I'm 25% European. And so how does that play in? But generically speaking, the things that I'm saying are significant enough to state emphatically. Mm-hmm.
Well, you come to the right place to stress the importance of nuance. Brett and I have been harping on this for ever since we started this program, that there is no black or white, yes or no. It's not right or wrong. There's always a variance, and we want to account for that. And that is something that sometimes gets lost in the shuffle, right?
Absolutely. And nuance is important in all of life, and particularly in medical care.
So for those of you watching we mentioned the School of Medicine, Morehouse, for those of you who are not from the US or not from the South, Morehouse is, as Aaron said, it's kind of the Black Harvard. It's also the school from which Martin Luther King Jr. graduated. It's many big leaders in mostly African-American leaders in the US. I have to say male African-American leaders, because Morehouse is an all-boys college. And the sister school across the street is Spelman. That's for the ladies. But that's one of the cornerstones of post-secondary education for African Americans. Would that be fair to say, Aaron?
It would. And because my daughter went to Spelman across the street, which is the sister school, they would say that Spelman is an all women's college and Morehouse is an all men's college, as opposed to girls or boys as they try to create the next generation. But you said it just right. And Coretta Scott King went to Spelman, right across the street from Martin Luther King and many African American leaders. When I should also just say, our current president, she went to a historically Black college university. She would take issue with the allegation that Spelman would be the best women's college.
Where did Kamala go to? She went to Rice. No, where did she go to?
Howard. Went to Howard and
yeah, that's right, the Howard. Yeah.
Oh, there we go. This is a whole nother cultural story. We should talk about this. We should make this an episode, Brett, about the different colleges and the allegiances and how there's rivalries between the schools in the U.S. for outsiders like Brett and I coming to this country. I don't know about you, but when I first came here, all this one college pitched against the other and all these allegiances and rivalries was like right over my head. No idea what that.
Yeah, I remember the first time seeing a college football stadium, and it was in San Francisco, right? So I'm going by, and I said, "Oh, is that where the San Francisco, what's the 49ers? Is that where they play?" I said, "No, that's just the school, and it holds 100,000 people." I went, "You what now?"
Different cultural issue here. So
that's huge. Yeah. No, definitely fruit for many episodes, probably.
Yeah.
So Aaron, I'm gonna poke the bear a little bit, the personal bear. My family and your family, we've known each other for what, 15 years, as long as our youngest daughters have known each other. The inequalities and the lack of inclusion in U.S. society is something that we've discussed over many meals and many adult beverages, and yet your family is at least in my perspective, one of the poster families for being unapologetically successful as African Americans. Both your wife and you and your daughters are doing marvelous things. So how important is it for the perception of Black leadership in general to have somebody like you serve in the role that you serve in? Is that also changing the perception of equality and inclusion in healthcare?
Oh, fantastic question, Christian. So in my world, I'm president and CEO, and I travel around. Okay. And one of the things that happens when I travel to our locations, so our frontline caregivers, we don't have many Black people in our organization. Again, not because we're a racist organization, because lots of Blacks just don't work in senior living and don't work in healthcare. When they do, they're usually at the primary caregiving level, which means often they're the lowest paid employees, and sometimes the ones treated the most unfairly. Okay, so when I walk through a campus, I can speak to the CNAs as comfortably as I can other CEOs of other organizations because of my humble roots. I mean, I did not grow up rich. I didn't know we didn't have money until I left home and I saw how other people lived. I had lived with both my parents. All of us went to college, which was rare for the time. But to answer your question, me just being in place, I have employees who write me, who tell me how inspired they are just that I am here, and that in the position that I am in, and that they were thinking of leaving, but they're going to stay because they want to help me be successful. And so the role of senior leaders in any organization, but particularly healthcare, is impactful in and of itself. Now, it's not enough just to say I'm going to walk through a few buildings and inspire some folks by my presence. No, I do more than that. I mentor people. I give back to the community of my time. I do all sorts of things to try to change that narrative. But I have to admit, just my physical presence alone does a lot. And again, you have to be intentional. I whenever I'm looking for a role, I always want to see if there's someone of color, not just Black, but someone who has been historically, underrepresented. I always want to see if there are people out there who are ready to make a move from where they are to come. They don't get an advantage, but they do get a fair shake at an opportunity.
I think that's a distinguisher that often gets misconstrued by the majority population, right? So where do you find yourself justifying that position because there's majority white employees or people that you engage with that say, well, you're giving a leg up to those who have been traditionally marginalized, but what about me? I need a leg up too. I might be white, but I've been treated unfairly for other reasons. So you're playing favors, Mr. Webb. How do you respond to that?
So I'm blessed to work for a company that has in its mission statement that we advance health of all people, regardless of faith, gender status, and we advance social justice for all. Right. So it is I make no apology for seeking out not just people of color, but anybody who's been historically underrepresented for a number of reasons. I mean, again, we are a Catholic faith-based organization. We don't discriminate on what your sexual preferences are, what your race is, whatever it is. You were created by God. We believe, and you are owed an opportunity to be heard, to be seen, to be felt. So no, I haven't heard those types of remarks. Do I know they exist in some people's minds? Absolutely. But when you look at the thousands of people who work for us, and other than me, when I started, I'm the only leader of color in my entire CHI Living Communities organization, which is thousands of people. Okay. So that's a conversation I'd be willing to have at any time if somebody wanted to have that conversation. I mean,
Yes.
and I'd like to witness and be a fly on the wall because I think that'd be great. No, and it's only because, and I say this in all best intent, it is masterful to watch somebody like you as a leader, honestly, achieving what you've done, accomplished, and passing these achievements and inspiring your children and other people around you. These are things that I would sit around all day and watch. It's like sport. It's like watching sport. I think it would be great. I think it's fantastic. And I wish there were many, many more like her, and may there be in the future. So,
I and having friends like Christian and Brett, we'll be friends forever now. We talk about these things openly, and that's what. And I'll say this too, Christian. I think that the way you build bridges between all sorts of obstacles is just through open, transparent conversation. And what Christian can tell you, when we get together with our spouses and we're drinking and eating a great meal, there's nothing that's off limits. I mean,
no holds barred.
There is no holds barred. That's the only way really can bridge understanding between cultures, is to be willing to have conversations that don't offend, that typically maybe would offend you, but you have to be able to ask. And we ask questions about German culture, and they've taught us a lot about German culture and history and heritage, and we have done the same from the African American perspective. But our rule is there's nothing you can't ask. You can't be offended. You can't take offense, and so I would just
you can take offense if you're willing to listen to the explanation and then have it brought back down, right? Yeah,
absolutely. The only way you get understanding culturally in any, whether it's healthcare, whether it's the work that you two are doing, just bridging culture gaps across all industry, have to be willing to be slow to take offense, but more willing to be transparent, open, and have conversations just like you would in your home. I mean, that you have to be willing to talk as comfortably as you would in your own home.
I had I've just had the good fortune to start off on a diversity and inclusion practitioner course. And yesterday, the cohort, there were two things that really stood out to me, and they were about intent and impact in terms of conversations. But there were these two things. One was calling in rather than calling out.
Right.
That concept that it's not calling out somebody for their mistakes, it's calling it in. Mm-hmm. It's bringing it in, it's understanding it, right? And also the difference between how you receive something being an ouch versus an oops, right?
Absolutely.
It's a different way of looking at it. It's a, oops, there was something about that didn't sit well with me, and I want to share it. And there were these, and so I'm, really excited. I'm only at the start of this, but I'm really excited to hear from these people how they practice that in real, because I'm certainly guilty of not practicing in an effective way, and I want to learn. And I think everybody can. So that was just those two things: calling in versus calling out, and an oops rather than an out. Like that kind of, yeah.
What's so impactful when I began in this role? I'm Black, but I'm not comfortable talking professionally about things that I've experienced in my life, injustices I've experienced, things like that, until I got to this role. And in this role, we have, I have a nun who reports to me, and she told me during the interview process when she was interviewing me for this position, she said, you can bring your whole self to work. You're expected to bring your entire life set of experiences and circumstances to work in this organization. And so we call them sisters. The sisters have created this open conversation where everybody's expected to be transparent. And so for the first time, I'm now professionally expected to talk about my racial injustices I have experienced so that others can learn from it. First time ever I'm 40, I'll be 47 next week. First time in my entire professional life, I am expected to have uncomfortable conversations to talk about my experiences. And I have many, okay? I have many. But you just learn, your parents, when you're Black, they teach you to just keep it moving, because if you stopped and had a deep conversation about everything that you experienced in life, you wouldn't get anything done. So I'm used to learning how to just take it on the chin and keep rolling and only call out the big ones. But you know what I've learned by sharing my experiences? There's a lot to be learned in what I consider small experiences that blow the minds of others.
It certainly blew me. You shared some of those with us, and I sat there not knowing how to respond because it was unfathomable to me that something like the experience you shared would be even possible, right? So this is what Robin DiAngelo describes as white privilege. We don't even know what's going on or what's possible. And thank you for being candid.
Absolutely. Thank you all for having this show to encourage others to be candid. And you can invite me anytime. I'm a willing participant. I now know to have a land or hard Ethernet connection instead of a Wi-Fi connection. So that's experience, but call me anytime. More than happy to chat on any topic.
So before I let you go, I want to let the world know that this is where they find what you guys do. homeishere.org. ORG because it's a nonprofit. It's a Catholic nonprofit. For those of you watching this want to know more about senior living in the way that Aaron's organization has built, so this is where you would find out about it. Aaron, what would you tell young professionals or aspiring young professionals who come from marginalized, disadvantaged communities, whether that be African American or any other form of disenfranchisement? What would be your advice? How should they go about entering, especially the field of medical and care, to make their voices heard and bring in all their experiences to make healthcare for everyone better?
Right. So I love that thought, and this is something that it took some age and experience for me to get to, but I'll say it. That is, never lead with fear. Okay, so there's no place for fear, I think, anywhere in life except for self-preservation and some very specific physical danger situations. But we've learned to adapt to fear in a way that makes us not be as forthright as we should in the things that we're interested in. And so I would encourage anyone, any leader, to find when you think there's something that you want to do, ask people to help you learn if it's something that you really want to do or not. And if you are in healthcare and you want to be a leader in healthcare, and if you are Black or from some other historically underrepresented group within healthcare, there are organizations out there that can help you connect with other leaders. Use LinkedIn. Put on LinkedIn that you're interested in healthcare, just as one example. Because one of the things that, Brett, you mentioned earlier that we talked about here, let me say it this way. Most people get jobs due to knowing other people who are in a position to offer them that job. Okay. So when I'm looking for a healthcare leader, I don't go to the open world and say, hey, any healthcare leaders want to come join this organization? I go to people who I know. And I say, hey, are you interested? Or do you know someone who's interested? And so that's the way leadership positions in any industry of any race, that's how most of them are filled, is through people you know personally or people that know someone that you know. So I would just say network. And network's not a fancy word. It just means meet people you don't know. If you have a bunch of LinkedIn connections and you don't know who they are, you just accepted them because they sent a link request with you, message them and say, tell me who you are and what you do and how we might be able to work together in the future. Nothing to lose.
Hmm.
So to me,
all right. So lead without fear. Love it.
No, there's no place for fear in this world. There's no place. You're not going to be successful in anything if you're fearful. And I've learned the hard way. I haven't always been fearless, but I can tell you I am fearless now.
Says the man who just married his oldest daughter off to a Navy SEAL.
yeah. Let's go down that conversation rabbit hole, shall we?
No fear. He's a military guy. He joined the Marines the same around the time my daughter started college, and they just married this weekend. Wonderful young man, service to the country, beautiful family. I'm hoping in the next no more than 3 years, they give me a grandson. Because I'm a man who was married with 3 daughters, and so I'm looking for a little testosterone in my group to balance out, to balance things out. But whether they have boys or girls, I will love them equally. But I am looking to be a grandfather in the next 3-ish years.
So Nia Webb, as you watching this, no pressure at all.
No.
You heard your dad. Hey, it's all good. Just 3 years top, and make sure it's a boy, right? Get to it, girl.
After that.
Oh man, Aaron, thank you so much for joining us today. I know you got stuff to do. We don't want to keep you. This was lovely. Great insight. I'm proud to call you a friend, and marvelous. Thank you.
Well, I appreciate that. And if it's okay, Christian, people send a LinkedIn request if you like. My work email address is aaron.webb@commonspirit.org. There's aaron.webb@commonspirit.org. And if you want to extend your network and have a conversation, I'm wide open. So thank you for the platform.
Excellent. Awesome.
We're very grateful, Aaron. Thank you very much for your time.
Thank you all.
Two Chaps Mini Cultures, episode 163, out for now. This was a good one. Not that the other ones were not good, but I particularly like this one. And we'll all see you again tomorrow. What time tomorrow, Brett? Tomorrow's an early one, so 8 a.m. Eastern. And that will be 2 p.m. Central Europe, so make sure you're on it. And for now, Two Chaps are out. See you again tomorrow.
Bye-bye.